Hi everyone, it is, what is it? It's Tuesday evening, 6 o'clock, and I want to quick get some information out there on chapter 33 for you. Now that I've figured out this Adobe audio, I am rolling, so I hope to catch up with all of this, these extra little sessions that I want to throw out there that cover some of the content of the chapters that I think that are sliding by a little bit in our classroom activities. So here we go, COPD, lower airway dysfunction, talking about chapter 33. And we did a nice wall map on this, concept map on the wall last week, and so I'm just going to cover some basics and maybe a little bit about the medications. So again, in review, over 10 million people in the U.S. are diagnosed with COPD. It's an inflammatory respiratory disease. Excuse me. Cause is chronic exposure to irritants. So I guess you all know and can guess that cigarette smoking is the biggest culprit in this disorder. Some of the key elements of COPD is that exposure, resulting in airway inflammation and then an airflow obstruction. Remember, these folks are CO2 retainers, and we talked about emphysema and chronic bronchitis being subcategories of COPD, but as your book says, this is kind of the old way we used to talk about COPD, and it no longer really stands. And so you can read your book more on that if you'd like. Anyway, how do we diagnose COPD? Well, signs and symptoms, careful patient history. So there's a chart in your book, 33-1, that goes over some of the questions you can ask patients surrounding potential history and diagnosis of COPD. We may do an ECG. We're going to do CBCs on them. We are looking for high red blood cell counts because as patients get hypoxic, we call that polycythemia, we increase our production of red blood cells so that we can increase our O2 carrying capacity to those cells that are screaming for O2. Also, we do spirometry, and that is broken down for you more simply on table 33-3. When we talk about spirometry and we're talking about pulmonary function tests, and we're also talking about peak flows. And so when we look at one of the characteristics of a COPDer is that they have a prolonged expiration time. We looked at that forced expiratory volume because it takes them a long time to exhale. So that's a key factor in that spirometry. So review that FEV levels or forced expiratory volumes. Some other symptoms you see with these patients, and the first signs that you might see in COPDers, and they can be very asymptomatic for several years and be diagnosed with this and not ever know they have it. Actually had a guy at church who was having some chest tightness, and that's what they finally narrowed it down to was COPD. But the first thing that patients may see is a chronic cough or maybe sputum production. Obviously, shortness of breath can be a sign, a first sign as well, but cough seems to jump out in the textbook quite a bit in several cases. Wheezing, typically. Barrel chest, if they have hyperinflation of their lungs, they develop that barrel chest, and we talked about that anterolateral ratio in class the other day. They may be using accessory muscles. So the three primary symptoms of COPD is cough, sputum production, and dyspnea. The patho is not too, well, it can get real involved, but I'll break it down simply for you. It's a chronic inflammatory response. It results in airway edema, mucus, hypersecretion. You get ciliary dysfunction, pulmonary hyperinflation. We talked about that's where that barrel chest comes from. And if it all continues, you get cor pulmonale as that And remember, we talked about cor pulmonale being that complication that exhibits itself as right-sided heart failure. And that's from pulmonary hypertension and enlarged right ventricle. So your book goes into that a little deeper, that patho. What's important for you to know that's a complication, know how that presents itself, and how would you identify or help your patients monitor that complication at home. So when we talk about heart failure, we talk about excessive volume or fluid overload. And we talked about the best indicator for measuring fluid volume status to teach patients, and that is to take those daily weights at home. Other patho that surrounds it, the alveolar walls break down and collapse subsequently. When they collapse, there is no gas exchange. They also lose elasticity. It increases your pulmonary dead space, so you have less area for gas exchange, and obviously that's going to go down. So you can't take in O2, nor can you, because you're air trapper, nor can you release your CO2. So you become a CO2 retainer. And some of those symptoms that we see in patients that are hypercapnic, which is CO2 retention, is headache, fatigue, and lethargy. And remember, I told you these patients get very, very sleepy. They can run very high CO2 levels in the 60s and even low 70s. But we really start getting concerned about it when they start becoming symptomatic, becoming lethargic, because they will lose their drive, their respiratory drive, and they'll have to be intubated and mechanically ventilated at that point. So we also covered this in class. Decreased O2, increased CO2 results in respiratory acidosis. So that's what you would see in these patients. So other complications that we're looking at besides cor pulmonale, polycythemia we talked about, which was the increased number of red blood cells. You'd see greater than 55% RBCs as the body tries to increase the number to carry O2. And then exacerbations of COPD. The biggest cause of exacerbations is the development of an infection. Some other things, PE, pneumothorax, rib fractures or trauma, opioids, sedatives, beta blockers, and CHF. Those are all causative factors of exacerbation. So those exacerbations, like in asthma, it's a sudden increase in the respiratory symptoms, and we already said infection was that most common trigger. Some patients in those times of an exacerbated episode develop indications for ventilator assistance, so they would maybe need to be intubated and ventilated. And those parameters, there's a list in your book, but I'll just list them for you here. Respiratory rate greater than 30, restlessness, severe hypoxia. Typically restlessness goes with severe hypoxia. Decreased level of consciousness, and even a respiratory arrest. So the goal of intubation and mechanical ventilation, I am sorry, that's my dog hearing in the background. Okay, hopefully I got rid of the sound effects, the background noise. So the goals is to buy some time, is to rest those respiratory muscles and to increase gas exchange, obviously, so that we can alleviate the cell death that goes on in those scenarios. Page 890, table 33-1, has talks about the history and the physical and the questions that surround some of these patients and what to look for. Typically in your COPD years, you're going to see wheezes, maybe crackles, especially if they have cor pulmonale as a complication going on. Remember, they're going to be fluid overloaded. They may be in that tripod position. We talked about that in class. Prolonged respiratory phase. Shortness of breath will be severe. Weight loss can be common due to shortness of breath because these patients can't eat due to shortness of breath. They can't catch their breath. Their respiratory pattern will be shallow and rapid. It will be inefficient. And so those are things to to recognize when patients are having an exacerbation of their illnesses. So we as nurses are to improve their airflow and prevent the disease from progressing. One thing we can do is help the patient identify or remove any pulmonary irritants. O2 therapy, obviously, that's the first thing we want to do is sit them up and throw a little O2 on them. But again, we talked about this, no more than 2 liters of O2. You must know their baseline. If you give them too much O2, they will lose their respiratory drive and they will quit breathing on you. So a couple liters is max, and make sure you know what they're on at home. And I would safely increase that by 1 liter in-house. The parameters for O2 therapy are that we would like to see their PaO2 greater than 60 on ABG and their SaO2 equal or greater to 90. Again, we chatted about this in class. You have to know where this patient lives. If they live at 85, 90 might be really pushing it. You may be shooting for 85. So it's important to gather that careful history. Table 33-4 talks about smoking cessation and the physical changes that happen over time after a patient quits smoking. We talked a little bit about that in class and how much your risk of developing illness diminishes as time goes by. Page 892 starts a long section on pulmonary rehab. It's important that you all read over this so that you can be prepared for the little specific things, the patient education things, such as pursed lip breathing, nutrition, those types of things. We like patients to utilize pursed lip breathing so that they can prevent complications and reduce air trapping in their lungs. So they breathe in slowly through their nose, hold their breath for about 3 seconds, then purse their lips like they're whistling and exhale for 6. And this helps them to prevent air gulping when they're short of breath. It also helps them to relax, decreases that panic mode, because these patients are very anxious, very agitated, and very air hungry. So they panic. And so that psychosocial status is a huge demand on nursing care. This pulmonary rehab section goes into direct and controlled coughing, so read over that. Nutrition. These patients can either be underweight or overweight. If they are short of breath, we certainly want to encourage them to increase their fluid intake because that's the way to best loosen the secretions. 6 smaller meals a day. They might rest before and after they eat. If they are overweight, they should try to lose weight. So they may need a dietary consult. So your interdisciplinary team becomes important. Pharmacologically speaking, Table 33-5 addresses this. Drugs, beta-adrenergic agonists, such as bronchodilators and albuterol. Bronchodilators is the #1 drug that these patients take on a regular schedule and actually use extra PRN for activities that may increase their shortness of breath. So that's the front line. These bronchodilators help decrease airway obstructions, relieve bronchospasms, and increase alveolar ventilation / gas exchange. Let's see, other drugs, anticholinergics, corticosteroids, methylxanthines, those are some other drugs. Steroids are reserved for those with severe disease or with a severe exacerbation. You see COPDers when they come in and they're admitted with COPD exacerbation, you see them on salumedrol, about 60 milligrams typically every 6 hours. What does steroids do for our blood sugar? It increases our blood sugar frequently. So frequently you will see these patients on Accuchecks just to cover their blood sugar. the elevations in their blood sugar accompanied by a sliding scale. These patients, we don't want to give them any cough suppressants. Again, water is the expectorant of choice. They need flu vaccines, pneumonia vaccines. With their drugs, they might use an MDI, a DPI, or a nebulizer. So 897 goes into those 3 different methods of administering. Most of the time you see us use an MDI, which also is referred to as a spacer. That DPI is breath activated, so the patients need less coordination with taking a deep breath and inhaling that medication. And then nebulizers we use all the time in the hospital in acute illnesses or in patients that can't use inhalers. That's when they are indicated. Remember, we talked about the side effects of albuterol. Patients can be agitated, restless, nervous. They can have tachycardia. So those things are important to teach your patients or to expect when your patients are getting breathing treatments. When patients are in severe respiratory distress, especially in acute asthma exacerbation, they will get a 10-minute long neb. And so they will be bouncing off the walls when that treatment is over. Let's talk a little about oxygen. Pulmonary rehab goes into this as well, and that is O2 indicators are a PaO2 under 55, an SaO2 less than 80, any tissue hypoxia or obvious organ damage. So page 899 is that red flag chart that I really want you to be aware of in these patients. It talks all about O2 and its role and how you should manage O2 in COPD patients. We want to titrate that O2 so their SaO2s are less than or greater, equal to or greater than 90. Let's see if I can spit this out. And the patients are free of respiratory distress. Your book also does a nice job of clearly explaining pulse oximetries or your SaO2s, and that's on page 897 and 898. So everything you ever wanted to know about a pulse oximeter is right there. Surgery is usually not indicated. There are some surgeries in very end stage and special cases of this. Lung transplant is an option for this, but typically those lists are long, and a lot of patients will die before they get their lungs. When we're talking about patient and family education, of course, trigger avoidance. Living in places where there are no temperature extremes, because that is also a trigger for an acute exacerbation. It's a good idea to have a home health nurse go out. We'd like these patients to avoid stress or emotional distractions. That also can trigger an exacerbation. They need energy conservation measures. Work needs to be simplified to conserve energy. Time management to group task if they can, or rest periods between tasks, whatever's indicated, and then follow up with their primary care physician or a lot of times their pulmonologist, whoever's following their COPD. Both of those people are very capable. In the more severe cases of COPD, you will see them go to a pulmonologist, or if they have a primary who doesn't want to deal with it, which is rarely the case, then they will send them on to a pulmonologist. That's about all I want to say about COPD. I'm going to go into asthma. So asthma, any age, interferes with both school, work, and exercise of individuals. It's a chronic inflammatory disorder. It is characterized by episodic exacerbations and acute inflamed airways. The death rate is highest in the 15 to 24 range, African Americans mostly. So you see African Americans and kids being the highest groups to develop this disorder. What happens is you get a hyper-responsive airway to a trigger or something that stimulates it. When that happens, you get bronchoconstriction or obstruction. You develop mucus plugs, and the symptoms occur. Some of those triggers can be allergenic, pharmacological, environmental, air pollution, occupational, infectious, or even exercise-related asthma. Those triggers are laid out for you in a nice table, 33-3 on page 901, so make sure you review that. And when we talk about death from asthma, there is a red flag alert on page 903 that talks about risk factors for death in these patients. But characteristic triggers, the things that you'll see when someone's asthma is triggered is wheezing, breathlessness, chest tightness, and cough. Some of us probably have asthma, I don't particularly, or know someone who has had asthma. There are two phases of that inflammatory response, both early and late, that your book speaks of. That early phase happens 90 minutes after exposure. Patient develops a cough, bronchial edema, and airway constriction. And the late phase of the patho develops. Okay, so late stage, 3 to 10 hours after exposure. It can last several hours to days. Airway obstruction, hyper-responsive airways with edema, increased mucus production. Those are the characteristics of a late inflammatory response to a trigger. Your book does cover a little bit, talks about latex. And some of the symptoms you can have from latex. If it's involved, that's urticaria, which is hives, angioedema, bronchospasms, conjunctivitis, rhinitis, anaphylaxis. So there's 3 big words in there that no nurse ever wants to see or hear, and that would be angioedema, bronchospasm, and anaphylaxis. All of those are life-threatening and require rapid treatment. The complication that we like to avoid, and we talked about, is status asthmaticus, which is a severe attack with a bronchospasm. You get hypercapnia, which is CO2 retention, remember, and hypoxic respiratory failure. These patients can quickly deteriorate and even die in just a matter of minutes. So we will need a rapid assessment and identification. And these are the guys, they come in, they're moving very little air, they can't really speak, they may even be cyanotic, they have low pulse oximetry. So it's not really hard to differentiate these patients when they're in this kind of trouble. They get high-dose corticosteroids, short-term bronchodilators, O2. Albuterol would be the drug of choice to give to these patients. And the treatment duration in status asthmaticus depends on the patient's response. So we'll keep pumping them full of albuterol. We'll give them a 5 or 10 minute neb and maybe some Atrovent with that. And if they don't convert or if they're not turning that corner, then we can just repeat those. So I always tell people they're afraid to hit their albuterol inhalers at home too much, but you realize when they come into the hospital, we're giving them nebulizers in large doses over long periods of time to open up their airways. So the thing that I educate my patients on is just keep hitting that inhaler and just keep hitting that inhaler, that it's safe. That's one thing we kind of fall short on that we don't really get across to these patients, is how much of that inhaler can they have, especially when they get into trouble. If these patients retain CO2, if their mental status becomes altered, if they poorly respond to this treatment, or if respiratory failure is impending, then they are intubation and mechanical ventilation is indicated. Make sure they have an IV access. You want to be very careful about the volume in these patients. They can become hypotensive. So you want to be ready to go to cover that as you intubate them. As far as history goes, typically asthma patients have some personal or family history of patients. Again, though, I love these different diagnoses or disorders because they all have nice questions laid out in boxes. So 33-2 talks about the questions to ask a patient with asthma. Certainly, you'll want to know physically what their symptoms are. So all of those symptoms that we talked about already, chest tightness, typically symptoms worsen at the night or with exposure to the trigger, which seems pretty commonsensical. Their respiratory rate may be up, they may be tachycardic, they may be suffering from pulsus paradoxus. They may be utilizing their accessory muscles, so if you need to, especially if it's a kid, pull up their shirt and watch for those rib retractions. They may be hunched over, they have chest deformities, nasal secretions may be increased, and if they're bad enough, they may have skin color changes, pallor, cyanosis, or be in that tripod position. We diagnose asthma with pulmonary function test. Their forced expiratory volume will be markedly decreased, and these symptoms all improve with bronchodilators. Okay, so peak flow meters. Page 906 has a patient playbook feature surrounding these. Normal peak flow is 80 to 100% of the predicted flow of the patient. Height, weight, sex, and age all determine a normal, so it's individualized. Severe cases of asthma are less than 50% of that of predicted flow. So read over your peak flow meters on 906, your book describes as well. Chest x-ray may show hyperinflation or bronchial wall thickening in these patients. So nursing should manage fear and anxiety from shortness of breath because, again, these patients are very air hungry and very anxious. We need an education action plan, and in that are signs and symptoms to be monitoring, their peak flow monitoring, avoiding those triggers, prevention through and control. So medications for both prevention and control, which we'll talk about here quickly. And our peak flow, they talk about this 3 zones of control for these patients in your book. So the green is the good, the yellow is caution, and the red is healthcare alert. So just like a red light. Green, you go on through, yellow, you better slow down, and red, you need to stop and take care of the problem. So this directs their care. And these are all based on their peak flow meters. So the patients know at which levels they live and when they're getting in trouble with their peak flows. Pharmacologically, drugs are broken down into 2 categories of relief. Well, we have quick relief or we have long-term control. So quick relief drugs are utilized in exacerbations for prompt relief of airflow obstructions and bronchospasms. The drug of choice here is what was that called? Our beta something agonist. Beta adrenergic agonist, that's what it is. And so albuterol is very good for quick relief of a bronchospasm. Ceravent also is a long-acting to use in severe and moderate persistent attacks. If patients are using their quick relief meds too much, then this indicates poor asthma control. So the patient really needs to be looked at more closely for what their regimen and daily regimen is. Long-term control is designed to prevent and suppress the inflammation. These are regularly scheduled drugs. They may be on daily corticosteroids. Ceravent is one of those drugs that they may use. in more severe or moderately persistent patients with frequent attacks. But albuterol on hand as a quick relief is important for bronchospasms. No mucolytics, no anxiolytics, no hypnotics for these patients. They are contraindicated. Emergency management of a patient with asthma, and this is a really important chart. It's a red flag chart for you on page 909. So that talks about what you're going to do in a patient that's having an asthma attack. Cystic fibrosis, very interesting disease, occurs mostly in Caucasians. It's an inherited autosomal recessive disease. That means that a patient has to inherit one CF gene from each parent. It's chronic, it's progressive, and it's usually fatal. The average life of these individuals is 31 years, and that it's a disease of your exocrine mucus-secreting glands, which is part of your endocrine system. But this disease affects your respiratory, your digestive, your intestinal, your pancreas, your reproductive system, pulmonary, respiratory, obviously. So when we break down the symptomatology, we look at pulmonary and both non-pulmonary symptoms. These patients, the hallmarks of cystic fibrosis are two in number. The first is blockage of chloride and water ion movement in both the cells and the lungs. So they have issues with chloride and sodium. They can develop such low sodium levels that they can have problems with volume, because remember, where sodium goes, water goes. And so when they lose water, they lose sodium, and also become so hyponatremic that they may develop dysrhythmias. The other hallmark is increased secretions of abnormally thick mucus. And this can result in frequent respiratory infections, lung disease, malnutrition, infertility, diabetes, poor growth, and I think there's even more in the list in your book. So pretty interesting disease, not one that anybody wants to encounter or experience, especially when you see the population at risk tends to be, begins in your pediatric population. So some pulmonary symptoms. Remember, we said pulmonary, non-pulmonary. So chronic recurrent productive cough, wheezing, shortness of breath, recurrent infections, bronchiectasis, which is a dilatation and destruction of the bronchioles, infiltrates, scarring on your chest x-ray. You may increase your anterior posterior chest circumference, may have some atypical crackles. Non-pulmonary in nature, sinusitis, nasal polyps. What else? Abdominal pain, diarrhea, liver disease, steatorrhea, so fatty stools. Rectal prolapse, patients may experience a lot of gas. So the diagnosis for cystic fibrosis is the sweat test, where the patients sweat out. A specimen is taken and they find increased sodium and chloride levels. For the pulmonary entities, we may do an ABG or a pulmonary function test. So certainly we are going to create our diagnostics around the symptoms that the patient is exhibiting. So what can nursing do? Well, help to clear and decrease airway secretions. These things are done through positioning, through O2, through postural therapy, chest PT, different respiratory and breathing techniques. There's a lot in your book of interventions that surround this, so take a look at those. We also need to decrease because of their increased risk for infection, their crowd exposure needs to go down. Avoid people with infections, good hand washing. Nutrition becomes very, very important for these patients. So box 33-3 goes into nutrition. It talks about a normal stool, a stool that you would see in a patient with CF. CF would be bulky and foul-smelling and maybe fatty in nature. If these patients have normal stools, it means that they have malabsorption issues. So dietary-wise, up their sodium, increase their intake of fat-soluble vitamins. They need iron supplements. They need pancreatic enzymes. Remember, the pancreas was affected. And they also need daily weights for fluid volume indicators. Pharmacologically, lots of drugs. Most of these are anti-infectives. Respiratory therapy, inhalers, all of those types of drugs are indicated for these patients with pulmonary symptoms. They need regular vaccines to avoid infections there too. Mucomist is one drug of choice to decrease the viscosity of solutions, and we give mucomist a lot. Sometimes in Tylenol overdoses, it's nasty. You give it IV, it smells like rotten eggs, but great drug for some issues. In kids, they actually can give them Motrin for the inflammatory response, and it has shown to diminish the deterioration of the disease in kids, but in adults, they really don't have any evidence that supports that. The only surgical option for these patients is lung transplant. And again, we talked a little bit about that in COPD. A lot of times they die on the waiting list, and you have to meet certain parameters to even get on the lungs. So your lungs have to deteriorate and be so poor functioning that before they'll even put you on these lists. But that is an option. Education-wise, psychosocial support, genetic testing is very much in play, especially for someone who is considering pregnancy. Home modifications, things to reorganize, to help their energy expenditure. End-of-life care if they're critical. So there on 913, there's a patient playbook that surrounds patient education of cystic fibrosis patients. And that's it. That's all I have to say on these four things. So please look forward to some more of these little chats. I hope to get a couple more of these chapters out on Adobe so that we can spend class time trying to drive home these concepts. Have a great evening, and we'll see you all very soon.